Mitch, I'll let you take it away.
Yeah, thanks, David. Appreciate you all joining and kind of hearing what our experience has been implementing some amount of PGx in our depression anxiety management in our primary care setting. So I'll discuss today like what our setting is like, what our practice model is, and what our pharmacists do. Discuss some of the things that we've thought about in utilizing a PGx panel for depression management, and then like what that implementation has looked like, what things are missing, what we still hope to do, and kind of ways that we're continuing to improve our processes. And then I would also like to speak to about specifically using our skills as pharmacists in this. Specifically, like we in our setting get a lot of opportunity to do some very pharmacist things that go beyond, I guess, just the PGx. And so I'd like to speak about that too, and then share a little bit of the evidence that we've considered in, going through this process. So our setting, or where we work, it's a nonprofit Catholic health system in West Michigan. So both Tara and I are based out of Grand Rapids, Michigan area. We have a pretty large primary care network, especially in West Michigan, many primary care clinics, and yeah, just pretty robust primary care setting. Um, we use Epic systems for our electronic health record. And then our pharmacists are in almost every primary care clinic, several specialty clinics in the ambulatory space. And in primary care, we have pretty broad collaborative practice agreement. So in the state of Michigan, physicians can delegate pretty liberally. Like our collaborative practice does specify disease states, but we don't necessarily have to specify protocols. And so our pharmacists are able to, order medications, labs, change the therapy plan and implement that for a broad area of disease states. I mean, really, the bread and butter is the metabolic conditions, but we definitely do other things as well. I know during kind of time in COVID, we did like a lot of Paxlovid referrals and doing like quick appointments to, get drug interactions sorted and prescribe Paxlovid to appropriate patients. But really, serving the needs of primary care, which are broad, and especially where they touch on medication management, like we're involved. And so that includes depression and anxiety. One thing that we have seen in, getting referrals for depression, anxiety management is often interest from primary care providers for pharmacogenomic support because of some, commercial products that are available that, advertise and lend themselves to saying like this PGx product, this will help decide like what medication is going to be best for treatment of patients, depression and anxiety. And so we'll get, patients asking directly for this kind of service, or, providers familiar with this service asking. And that is naturally kind of coming to our pharmacists as, hey, is this something you do? Can you help with this? And so it's had us consider like, okay, in the whole context of PGx, like, should we be doing this more? Why are we not doing this more? And some of it has been just access to, what laboratory services we need, the comfort experience to interpret the results that we get, knowing that, okay, I'm not missing something here. I'm not collecting information that I can to act on. And then knowing like, is this evidence-based? Is this something that would be recommended? Or is this just something that the patient has heard about that, may not particularly benefit them fully, or, they just might have a different idea of what it is telling them. So one, I guess, one piece of evidence that kind of directly relates to this question of a kind of commercial PGx panel looking specifically at depression, anxiety medications that fits the scenario that we're in, where we're saying like, okay, we have someone with depression, anxiety, maybe they've tried some medications and haven't had success in treating those. Is this beneficial to actually order the testing, and what improvement to the patient will we see? So this particular study from Oslin et al. Was done in a number of VA centers where they basically randomized two different groups, so like a usual care and then a pharmacogenomic guided treatment group. They specifically looked at depression in these, so not anxiety, but major depressive disorder, and really nice, practical, real world study where the usual treatment group got usual treatment, and the pharmacogenomic group got this pharmacogenomic testing. This was specific commercial product, and then they looked at outcomes. And the main outcome, kind of my opinion on some of this here, is that there was a significant difference in remission at 12 weeks. So remission being, low PHQ-9 score, but by 24 weeks, there wasn't really a significant difference between the two groups, at least at that 24-week score. In terms of like 50% reduction, there were differences at several of the time frames, 8, 12, 24 weeks. And so that's some of what we have been using when discussing with providers and with patients, like, is this type of testing going to be helpful? And we can say, well, there was a study where they did have patients go into PGx testing like this, and they got remission sooner, but by 6 months, like the treatment groups were similar to the control group. And so we kind of can set that as an expectation that it might help us get there sooner, but not necessarily, in the long run to have, better results, though, there's definitely benefit in sooner results. Some of the limitations of this study were that it was unblinded and really measuring patient-reported outcomes. So it's something that is a risk of bias when patients know that they're in the special care group, and the other patients know we're in the usual kind of same old treatment paradigm group, and they're reporting their own outcomes. It can possibly influence those. Some of the other limitations too were that this testing is sort of proprietary commercial algorithm for the PGx recommendation, so not necessarily consistent with CPIC guidelines. It's sort of some proprietary information, and that this can change. This company will update the recommendations, and so knowing exactly, okay, at the time that this study was done, was this using the same recommendations that I would get now if I order it 3 years later, is important to think about. But it was, like I mentioned before, very applicable to our situation, and is really what we find ourselves in often, is saying, okay, is this type of testing going to be valuable? So when thinking about okay, there's this commercial product we could be using. It is easy to use, and patients are maybe more familiar with it. But are there more robust strategies we could undertake to have a better PGx practice in our primary care sites, rather than just saying, okay, we'll use this one commercial product? Is there a different way to do this? And Dr. Natasha Petri et al. Published a recent study in AJHP looking and describing their process of implementing CYP2C19 and CYP2D6 genotyping to guide antidepressant use in their health system. And honestly, like, very impressive. So they, had a large team of clinicians, educators, informaticists, technicians, nurses, like really robust, kind of like end-to-end process, like from the actual lab orders itself to the actual EHR alerts and things like that, the actual clinicians doing it. And so just really like integrated, like front, start to finish. And also integrated not just those internal results for their program, but external PGx results, and basically has ongoing support through their pharmacogenomics division. And this is something that was helpful to look at and say, like, wow, this is like what a, kind of a comprehensive program could look like. But for Tara and I and our team was like, okay, we don't have an internal pharmacogenomics division. We don't have informatics support for our, PGx results. So we don't even have like a great way to put them in the EHR. Like, okay, this is nice, but this isn't where we are right now, maybe in the future. So what do we do? I guess I kind of just described this situation, but, I guess we'll tell you what we did. So some of, I think, the real positives that we have in our situation is that, like, our pharmacists do have very drug specific knowledge, that the level of detail is more than, what, the primary care clinicians often will have about side effect profile between medications, like what are the appropriate doses that we should be getting to for our antidepressant medications, like what is the titration schedule, like making sure that we get up to effective doses. We also can interpret those PGx results and apply them to practice in a way that, most of the primary care clinicians will be taking the, what's published in, say, these commercial products at face value. Like, we do know how to review in a bit more detail. We also have a lot of expertise in medication access. So when patients have issues getting the medication for cost reasons or just other really practical reasons, like, our ambulatory pharmacists know how to help them and do that all the time for many disease states. And then we have a lot of expertise in just educating patients on what to expect. How long does it take to get improvement with, with treatment, and what do the side effects look like? How soon do they start? How long do they last? How bad are they? Those sorts of things. Very, just pharmacist oriented, care. And a real positive in the primary care setting is our pharmacists can take time and have a very focused visit on, their mental health condition, depression or anxiety often. Not also having to balance some of the other things that, say, like our, our physicians and our physician assistants and nurse practitioners are doing, which is address the preventative care needs, like make sure that, all those things are updated, as well as, conduct a physical exam or, other sorts of things, address, multiple different conditions at the same time. That is difficult to get into all the patient education. And so when our pharmacists are just focused on, a certain condition, can really lend itself well to more kind of comprehensive care. Some of the barriers for our pharmacists in practice are that we don't have the same level of staff support as, our colleagues. And so we are doing our own scheduling. We're administering our own questionnaires. We don't have staff coming in and giving PHQ-9 surveys and then collecting the results and putting them into the EHR. Like, that's all us. It's a one-man band here, especially if we do order testing, PGx testing, like, okay, we're entering the order, we're collecting the swab, we're sending it off, like all of that is kind of happening by our pharmacists. And then we also have some other barriers in terms of just addressing the cost of testing, the coverage of testing, and areas where there is not total clarity to diagnosis, like our scope as pharmacists would not necessarily be to further differentiate someone's disease state in terms of like mental health diagnoses. I think we're equipped to screen and refer if there's concern for like emerging kind of bipolar symptoms or something like that if we're starting an SSRI. But as far as like actually diagnosing that, like those, we do have to kind of get them back to see someone who can. So Tara and I, along with Ashlyn Keebach and Jessica Benzer, published in JACCP last year and kind of described like what our pharmacist practice is like in depression and anxiety, and kind of collected over the last couple years, like how many visits and what those visits look like. And really what we found was that most of our pharmacists, when they were being asked to help with depression and anxiety, were having multiple visits with multiple interventions, a lot of starting new drugs, a lot of dose optimization, and we saw a significant difference in like the amount of SNRIs used. I think that was something that I think the primary care clinics weren't necessarily going to, and so it was an easy next step for our pharmacists to move into using SNRIs in treatment of depression or anxiety. And we found that about half of our patients had a therapeutic response, so 50% improvement in their PHQ-9 scores for depression. And then we just reported that we're currently using about we had about 35% rate of using PGx in these patients. So some of these patients were referred specifically for PGx, some were just referred for depression or anxiety. And so these were not necessarily all PGx referrals, but really ones where it was sort of up to the pharmacist to decide if they were going to implement PGx testing in discussion with the patient. And so that kind of leads us to like, okay, like when should we be ordering this PGx testing for depression and anxiety? Is it a patient who has failed one med, a patient who hasn't started medications, any patient who asks or clinician who asks, is it going to be, failing 3 meds? I think that's been one of the challenges for like us in our practice, is to know like what is the right thing to do here. So I am curious what other people are doing, like when they're deciding to order it, what those criteria are. Of course, we have good guidelines on what to do when we have the results, and how different genotypes will affect the metabolism of our drugs that we'll be using. But sometimes it's hard to know like when is most appropriate.
Yeah, and I think for sake of time, I'd love to. One of the things for those that have been around the Echo model for a bit is we love to leverage the chat feature too. So please feel free to throw thoughts in the chat here, and we'll keep coming back to that, and we'll open up this discussion even more once we get to the case.
I'll kind of move on a little bit from here and just describe like what our usual workflow looks like when we do order this PGx testing. We'll get a referral from the provider, and then usually conduct an initial education visit with a patient, which Tara will describe a little more in her case. And we have a visit with the patient first to say like, okay, what are the what are the expectations of this testing? What does it tell us? What doesn't it tell us? And then if we go forward with it, we'll coordinate that testing, and usually have either like in person with a pharmacist to collect it, or set up some sort of self swab for the patient, and then also set up a results visit where the pharmacist will meet with the patient either in person or by phone or video, and go through the results and make a recommendation. And then in some cases, and it mostly just depends on patient and pharmacist comfort level, the pharmacist may follow up for ongoing management of the initiation of that drug, and then follow up changes based on how things are going. And so this, the PGx testing and some interest from clinicians, patients, has been sort of a doorway for us to be more involved in depression and anxiety management within our primary care clinics, and has been something that we have found that, like, okay, we started with PGx, but really, like, setting expectations for treatment and effectively using the medication, and just careful titration, we've been able to like follow up with that and have success. So maybe just in the chat would be good, but would like to also know like how other pharmacist teams are, managing the workflow for this too. Just as a kind of primer for Tara's case, also we'll mention a drug gene pair here. So, when we're getting PGx testing and depression and anxiety, really a few key enzymes, the 2D6, 2C19, 2B6, really pretty important for a lot of the antidepressant medications. And we will talk a little bit about the star 1, star 3, which phenotypes to an intermediate metabolizer for paroxetine. So we would expect higher concentrations of paroxetine in a patient with this genotype. And they may phenoconvert, so basically become a poor metabolizer instead of intermediate metabolizer if they're also on CYP2D6 inhibitor like bupropion, fluoxetine, duloxetine, or if they're at even high levels of paroxetine, may kind of push them into that poor metabolizer status. And so might expect higher chance of side effects, especially at higher doses or faster titration with paroxetine in this genotype. And so we would consider starting at a lower dose or just titrating more slowly for these patients. Well,
Okay.
thank you, everyone.